Dr. Monica Marin is one of my colleagues. Very happy to be working with on a daily basis. She did her medical training at I think Carol Davila Medical School, and then residency in SUNY. Came here to OU for fellowship, and like me has stayed on. She is our expert in thyroid disease and thyroid cancer, and has worked really hard to develop our thyroid clinic here at OU. So very excited to hear about congenital hypothyroidism. With much further ado, we'll get Dr. Marin going.
Thank you, Jonathan, for nice. Can you hear me? Thank you for a nice introduction. We're gonna talk today about genetics of congenital hypothyroidism. The objectives of my talk are to identify major genetic mutations associated with thyroid dysgenesis and dyshormonogenesis, and to understand the significance of molecular markers in diagnosis, prognostic, and treatment. An overview of congenital hypothyroidism, as we all know, is the most common congenital endocrine disorder, ranges between 1 in 2,000 to 1 in 4,000 newborns. As primary congenital hypothyroidism, the secondary and tertiary causes are rare, are about 1 in 50,000 newborns, and majority of the congenital hypothyroid patients will gonna have a permanent form in 75 to 85%. The genetic causes of congenital hypothyroidism, though, are very rare. They represent only about 8% of the total causes of primary congenital hypothyroidism. We further divide the primary congenital hypothyroidism into thyroid dysgenesis, which is the most common etiology. It represents 80 to 85% of all the patients with primary congenital hypothyroidism. It is a consequence of abnormal thyroid gland organogenesis and results into agenesis or arteriosis in 20 to 30%, ectopic thyroid, about 60%, hypoplasia of an orthotopic gland, 5%, and more rare hemiagenesis. 10 to 15% of the cases are inherited defects of thyroid hormones biosynthesis or dyshormonogenesis. This is an overview of different genes and transcription factors that would give us genetic forms of primary congenital hypothyroidism, and we'll discuss each of them separately. We'll start with thyroid dysgenesis. It is generally assumed to be a sporadic disease. There are different arguments against the classic Mendelian inheritance of thyroid dysgenesis. There is high discordance between monozygotic twins, and there is a high female preponderance. Basically, all the steps, starting from the pluripotent endodermal cell all the way to differentiated thyrocyte and a migration of thyroid from the foramen cecum to its definite location, could be affected, and they are controlled by different transcription factors. Well, pair box gene 8 mutation. PAX8 encodes for thyroid transcription factor of the pair homodomain transcription factor family, which is also expressed during kidney development. PAX8 is essential for survival of thyroid follicular cells, precursors during organogenesis, and also for differentiation. PAX8 in synergy with NKX21 also regulates thyroglobulin, TPO, and sodium iodine. It's important expression. The biochemical and morphological phenotype varies from euthyroid to severely hypothyroid. Thyroid could be normal size, or we can have atheriosis. Kidney agenesis, though, is not always associated. PAX haploinsufficiency also could lead to decreased sodium iodine importer, and as a consequence, there could be low iodine uptake, scintigraphy, which sometimes could be misdiagnosed as dyshormonogenesis. I'm trying. Do you know how pointers? Oh, it's in the middle. Got it. Sorry. So here we have normal thyroid tissue, and here mutant PAX8. What is specific for PAX8 tissue morphology? We have very small or even absent follicles, which are similar with the fetal thyroid, and that suggests impaired folliculogenesis. And on specific staining, there is normal immunoreactivity for thyroglobulin, though the colloid is reduced. And there is also normal immunoreactivity for TPO, which shows that cells are normal. The functional mass is also reduced, and this leads to hypoplasia. We're moving to FOX E1, which is also known as thyroid transcription factor 2. This is expressed in the thyroid primordium, but also in the pharyngeal endoderm derivatives, palate and esophagus, and in hair follicles. FOXC2 is required for survival of follicular cells and plays a role in precursor migration during thyroid development. Mutation in FOXC1 results in Bamford-Lazarus syndrome, which is characterized by atheriosis, cleft palate, and spinky hair. NKX21, also known as thyroid transcription factor 1, is expressed in the developing thyroid, but also in the ventral forebrain and lung. And this leads to brain-lung thyroid syndrome, which is characterized by congenital hypothyroidism, but also very important hypotonia at birth, which eventually evolves to hereditary chorea between 1 and 5 years of age, and surfactant deficiency at birth, leading to interstitial lung disease later on. In this syndrome, hypertrophinemia is actually more frequent than overt hypothyroidism. Some patients might not be detected by newborn screen due to only mildly elevated TSH, and thyroid morphology could vary, could be normal in 55% of the time, could be hypoplasia or hemiagenesis development. So it presents very often with congenital heart disease, and sometimes congenital hypothyroidism, though congenital hypothyroidism in this mutation is very rare. It's working. Inactivating thyroid stimulating hormone receptor mutation, leading to thyroid stimulating hormone resistance. These are the most common mutation associated with thyroid dysgenesis. TSH receptor is the main regulator of thyroid activity in mature thyroid gland. Though TSH receptor is expressed in later stage during thyroid development than PAX, NKX2-1, and FOXC1, but long before the fetal hypothalamic pituitary thyroid axis and TSH secretion activation. It is generally assumed that TSH receptor does not play a central role in thyroid organogenesis. And mutations in TSHR gene are usually the most frequent cause of monogenetic forms of thyroid dysgenesis, and they represent about 4.3% of the cases. Depends on how we inherit the mutation. If there is a loss of function mutation in the TSHR gene, it's inherited autosomal dominant. They result either in partial resistance or total resistance, and again, the phenotype varies. The patients with most severe phenotype present with profound thyroid hypoplasia, without tracer uptake on scintigraphy and measurable thyroglobulin level. This is also called apparent athyrosis. Patients with partial TSH resistance could present though with eutopic thyroid, normal size, and they may not be detected by newborn screen. The severity of the phenotype depends on mono or biallelic inheritance of the mutation. In the same family, we can have individuals with homozygous mutations that suffer from more severe phenotypes and patients with heterozygous mutations that are very mild. GLIS3 mutations, these are very rare. This is another transcription factor, and it's involved in multi-system development and presents with permanent neonatal diabetes, renal cystic dysplasia, progressive liver fibrosis. Thyroid findings include thyroid aplasia, diminished colloid with interstitial fibrosis, or we could sometimes have normal thyroid texture on ultrasound. What is specific for these patients is that sometimes they present significant TSH resistance on appropriate treatment with levothyroxine. And this is transmitted autosomal recessive. Now, moving to thyroid dysharmonogenesis. This accounts for 10 to 15% of the cases of congenital hypothyroidism. And basically, all the steps in the thyroid hormone synthesis could be affected, but thyroid organogenesis is normal. It's often associated with goiter, which could be present in utero or at birth. The mode of inheritance of these mutations is in general autosomal recessive, with the exception of DUX2 mutation, which could be transmitted autosomal dominant. And the mutations leading to dyshormonogenesis are in general isolated, with the exception of Pendrin syndrome due to mutation of Pendrin. This is an overview of the thyroid hormone synthesis, just to remind you, and shows the genes that would lead to defects, different steps of thyroid hormone synthesis. Sodium iodine is important, Pendrin, and then the defects in organification and coupling due to TPO and hydrogen peroxidase generation here, and then recirculation of iodine. We'll start with iodide transport defect coded by SLC5A5 for sodium iodine importer, which is the limiting step of thyroid hormone synthesis. It is expressed at the basolateral membrane, and the severity of hypothyroidism depends on the residual function of the mutated sodium iodine importer. So could range from severe hypothyroidism to mild forms, and in areas with high iodine diet, patients might be euthyroid and present multinodular goiter. This is a rare form of dyshormonogenesis, but identification of an index case will allow subsequent preclinical diagnosis of other cases in the same family, avoiding delay in treatment and prevented developmental delay. Iodine supplementation might work alone in this condition or in conjunction with levothyroxine treatment. The key findings in iodine transport defect are hypothyroidism, goiter, but no radioiodine uptake. So on the left, we have scintigraphy for a patient with ITD, and on the right, a patient with atherosclerosis. So the difference between ITD and atherosclerosis consists of lack of uptake in the stomach and salivary glands, basically a Y scintigraphy, which is diagnostic for this form of dyshormonogenesis. Pendrin syndrome is coded by SLC26A4. It's a multifunctional anion exchanger. It is expressed in the thyroid, but also in the inner ear and kidneys. Pendrin syndrome presents with familial sensorineural deafness or hearing impairment, multinodular goiter, hypothyroidism. Hypothyroidism is congenital only in about 30% of the cases. Those patients could be diagnosed later on in infancy and childhood. Goiter develops usually in childhood, but could vary. And again, in areas with iodine deficient areas would present with hypothyroidism, but if we have a diet rich in iodine, patient could be euthyroid. The perchlorate discharge test will show a partial organification defect. We'll review images of perchlorate discharge test in the next couple of slides. And Pendred syndrome is not a very frequent cause of congenital hypothyroidism, but it's a frequent etiology of familiar hearing loss. And it represents about 10% of hereditary deafness. There are a few characteristic malformations in the inner ear, in the cochlea, and the vestibular apoduct is, this is normal here, and this is a patient with Pendred syndrome. So we notice the enlarged vestibular apoduct, and cochlea sometimes could be small. Mutations in the thyroglobulin gene. Thyroglobulin, as we all know, is the most abundantly expressed protein in the thyroid gland. It is secreted into the follicular lumen, where it serves as a matrix for hormone synthesis. And also it's a storage pool for iodide. But some of the thyroglobulin is released in the blood, and this makes thyroglobulin a useful laboratory marker for congenital hypothyroidism. And it's useful to screen for residual dysgenetic thyroid tissue with no radioactive iodine uptake or apparent arteriosis, but also to screen for mutations in dyshormonogenesis. So if we have a patient with TG gene mutation, the thyroglobulin levels will be low versus the other forms in which thyroglobulin could be normal or elevated. This is the most common mutation, or amongst the most common mutations leading to dyshormonogenesis, is estimated at 1 to 67,000, which represents about 1/4 to 1/3 of all the cases with thyroid dyshormonogenesis. So in this slide, we have the image, normal staining of the thyroid, but we can notice all the thyroglobulin being inside of the follicular cells and basically absent from the colloid. And it accumulates in endoplasmic reticulum, and on electron microscopy, you could see the enlarged endoplastic reticulum. Thyroid peroxidase gene, TPO is a heme peroxidase expresses the apical membrane of the thyrocyte. It has important role in two steps of hormone synthesis, organification of iodide, and coupling. The incidence of biallelic TPO defects, it's about 1 in 66,000. Most patients suffer from severe hypothyroidism, which is detected at newborn screen. Congenital goiter is frequent, but patients with heterozygous mutations could have only transient hypothyroidism. Finding TPO gene mutation in a neonate with congenital hypothyroidism indicates that the subject will require lifelong treatment. And also it's important for future pregnancies to monitor for goiter. So this is the actual perchlorate discharge test. First, patients receive 123 iodine. And in this panel, we can see baseline uptake. And then certain interval, they receive perchlorate, which will gonna wash out the non-organific iodine from the thyroid. So normally about 10% of the tracer will gonna be washed out. But if it's 90% or higher at the end of the test, this is consistent with complete organification defect. We spoke earlier about partial organification defect. Those patients will have usually a decrease somewhere between 10 to 50%. And in TPO gene mutation, thyroid is normal or enlarged at ultrasound, and also thyroglobulin, it's normal or high. The DUX2 and DUA2 genes, these code for hydrogen peroxide for the system that generates the hydrogen peroxidase. So the hydrogen peroxidase is essential for the TPO function. And it seems that only mutations of DUA2 and DUX2 are associated with hypothyroidism, not the DUX1 and A1 mutations. These mutations are inherited autosomal recessively. Some patients have only heterozygous mutations. So that suggests that autosomal dominant transmission, it's also possible for these two mutations. And monoallelic mutations usually cause only mild hypothyroidism, while biallelic mutations will lead to more severe congenital hypothyroidism. They also have a partial iodine organification defect. Iodotyrosine dehydrogenase mutations, these cause iodine recycling defect, and iodine is transported back to the follicular cell to serve for thyroid hormone synthesis. These patients suffer from hypothyroidism, goiter, and mental retardation. Characteristic for this mutation, they have high levels of MIT and DIT if we measure them in plasma and urine. On scintigraphy, we'll see normal iodine uptake, negative perchloride discharge test, and if we continue to follow with imaging, they have slow release of iodine over days. To summarize the forms of dyshormonogenesis based on iodine uptake, we have no or low radioiodine uptake in the thyroid and salivary glands and stomach. This is consistent with iodide transport defect in the sodium iodine importer. Another category is normal radioiodine uptake with positive perchloride discharge test, which is diagnostic for iodine or organification defect, which could be total in TPO mutations or partial in duo X2 and duo XA2, and also pendrin gene. And if we have normal iodine uptake with negative perchloride discharge, this is suggestive of thyroglobulin mutations or iodine recycling defect. We went through a long list of genes, but it's important to know why we would test and what is the clinical significance. So in cases in which we identify a candidate gene, we will have an underlying explanation of the disease, and we could predict the risk of thyroid and extrathyroid defects in affected families. Also, if we identify TPO or TG gene mutations, this would help us to tailor our thyroxine treatment to prevent goiter in these cases. Carriers of particular gene mutations are at risk for extrathyroid malformations in syndromic diseases. For instance, NKX2-1 mutations could lead to life-threatening respiratory disease. If we identify patients with mild TSH resistance, these patients might not need long life treatment with levothyroxine, and also patients with mutation for sodium iodine importer might benefit of iodine supplementation plus minus levothyroxine.
I was just going to ask if there were any specific genetic panels or more streamlined ways to test patients for these mutations, or if you need to kind of tailor to what you're looking for and identify specific genes to test for.
Well, I think if we suspect a specific mutation, we probably should test only that. In our institution, we do use a genetic panel, and I'm not for sure where that goes, but there is a genetic panel that includes most of these mutations.
Thank you for the talk. When would you do the thyroid scintigraphy? And second, at what point, if they did not have the clinical features, the syndromic features, and when do you suspect genetic causes of congenital hypothyroidism, and when would you order the genetic testing?
So I think we all agree that guidelines recommend to treat without imaging in neonates. I personally send genetic testing after I try to wean them off levothyroxine. And I have cases that are kind of borderline. They don't declare themselves one way or the other. Because if they are permanent and there are no other suspected malformations to think about the particular syndrome, we're not gonna change our treatment. But for some patients that are not quite normal and not permanent, sometimes we might have an explanation for that.
Okay, probably one more question.
Have you had any acquired cases that were like genotoxic where you've had like 4 or 5 people in a family or anything like that?
Yeah, I have a family with Pendred, but they are all affected differently.